Thank you so much, Katie, for telling us your story and also for the incredible work you have done and setting an example of how one person can make can build a community where there may not be one that exists. It's my honor to be here today. I'm Sarah Sutka from the University of Washington, the Fred Hutchinson Cancer Center, to lead a oligometastatic tumor board. I think one thing that the KCA exemplifies is the intense collaboration and multidisciplinary nature of the disease space of the community that we all work in that's absolutely necessary to care for patients who are dealing with kidney cancer. And so I'm, without further ado, going to introduce my panel. Let's see. There we go. And we've had a few changes to our lineup. We are sad that we were not able to have Dr. Haas and Dr. Al-Hamdi join us this week, but we are grateful to Dr. Martin Voss and Dr. Payal Kapoor for stepping in, and then also welcome Dr. Simon Lowe and Dr. Vitaly Margulies. So you can see here we have representatives from medical oncology, radiation oncology, urology, and pathology, and you're going to see how we all have to put our heads together to really take care of these patients. So our learning objectives are to review the multidisciplinary management of oligometastatic renal cell carcinoma. We're going to discuss how we make decisions in this space, how we select treatments, and how we think about sequencing treatments, and then review some novel approaches to managing oligometastatic disease. And I'm going to just introduce two definitions that I think are critical to understand how we think about and characterize these patients. So oligometastatic renal cell carcinoma is a fairly heterogeneous clinical diagnosis or patient population, but it specifically refers to patients who have a limited number of metastatic lesions at presentation. It's important that that presentation can be delayed after treatment to the primary tumor or synchronous with the diagnosis of renal cell carcinoma at baseline. And then ultimately we also risk stratify patients into favorable, intermediate, and poor risk. Oligoprogressive renal cell carcinoma is a little bit different. That's where there's progression in a limited number of the metastases, and we're going to focus specifically on the first clinical scenario. We have 3 cases and 1 bonus case if we are succinct in our answers, and so without further ado, we'll get started. So case 1, this is a 37-year-old woman who was referred for a biopsy-proven 10-centimeter clear cell renal cell carcinoma. She'd come to attention because she'd actually had some fever and a dry cough, and ultimately had undergone some imaging by her primary care doctor that led to this. She's otherwise relatively healthy. She does have severe obesity, but otherwise is well supported at home, is a never smoker, has a history of breast cancer and a paternal aunt and lung cancer and an uncle. Her labs at diagnosis were within normal limits, but this is the imaging presentation, so you can see the very large upper pole tumor in the right kidney that is largely necrotic. Her metastatic evaluation was negative, although we did note a small 3-millimeter indeterminate nodule in her lung. I think one of the things that we'll sort of talk a little bit about is the decision-making sort of from start to finish. So Dr. Margulies, let's have you start us off. Just looking at this imaging, as you're starting to think about planning this woman's surgery, any specific considerations you would have, any considerations for whether or not you'd think about a lymph node dissection in her case?
So this is a young patient. There's higher propensity for variant histology and higher propensity for local regional nodal disease. So I would offer her nephrectomy and lymph node dissection at the same time. Probably nothing crazy, paracaval in this case, probably.
Any thoughts about her anatomy and how you would approach the tumor?
So she's large and the liver seems to drape over the kidney. But I would probably try this robotically and be ready to convert if this wasn't going my way.
So she underwent a nephrectomy. In this case, it was done through an open incision just because of the fact that her liver actually extended down to her iliac crest. And so we were able to flip that up fairly in a straightforward fashion. Dr. Kapoor, could you walk us through her pathology?
Yes, so on the left side, we are seeing H&E images which are representative from her nephrectomy specimen, and what we can see is a tumor which has rich vasculature and is composed of cells which have some clear cytoplasm. nucleoli are present, grade 3 grade. So in this kind of scenario where it's a young patient, I would also look at the normal kidney just to make sure there's nothing, no sequelae of germline disease. CA9 is diffusely positive, it's membranous. It's not just patchy, and so that goes along with clear cell.
And thus it's consistent with her renal mass biopsy. So she ultimately had a 10 centimeter grade 3, ISUP grade 3 to 4 clear cell renal cell carcinoma. The lymph nodes were all negative. We followed a similar template to that identified by Dr. Margulies. We did note, as expected based on the imaging, a high degree of necrosis, and the tumor extended into the perinephric tissue, so it's a PT3A. N0 renal cell carcinoma. Adrenal gland was negative and our margins were negative. She had no sarcomatoid or rhabdoid differentiation. Any thoughts about what this pathology confers in terms of risk for recurrence, Dr. Kapoor?
Yeah, so the major risk stratification parameters are stage, grade, presence of necrosis, sarcomatoid, rhabdoid, largely. And here you have a large tumor, grade 3, so high grade, necrosis is present. So overall, it's an intermediate risk. It is sarcomatoid, rhabdoid features are not present, margins are not positive. It's not infiltrating into the renal sinus, which is unusual. I would think that this larger tumor, which is clear cell, would generally go into the renal sinus. Here, you're just seeing perinephric fat invasion. But I would say 5-year survival would be just a little less than 50%.
Dr. Margulies, how would you counsel this patient regarding her risk of recurrence, and is there any workup that you'd recommend right now, and how are you going to follow her?
So she has multiple adverse features: large tumor, T3 disease, young patient, a lot of necrosis. So I agree with Payal. I mean, I think her risk of recurrence is substantial. So she would automatically be referred for at least a conversation with the medical oncologist about adjuvant therapies and things like that. I assume she came into this with pretty good staging. I think, she's young, clear cell. I mean, she would get probably genetic testing, germline testing automatically at our center. And in terms of surveillance, probably very careful every 3 months imaging for the first year at least.
Absolutely. Dr. Voss, so this patient was initially diagnosed in 2018. So retrospectoscope on, how are you going to counsel her about adjuvant therapy then and then of course now?
Yeah, so I agree that she deserves the discussion of adjuvant strategies. 2018, so adjuvant sunitinib was FDA approved in 2017, so she did have an adjuvant option at the time. That trial, the S-TRAC trial that put that drug on the map at the time, showed the DFS benefit in patients that received sunitinib for a year compared to placebo. But there was a lot of controversy then because another randomized study that ran through the cooperative groups here, the ASSURE trial, failed to show that same benefit in a slightly different patient population. Also, the size effect of that benefit was somewhat limited, was a hazard ratio of, in the high 70s. There was no overall survival benefit despite very long follow-up on the original publication, which is different from the pembro data that we're going to talk about. And there wasn't much appetite for sunitinib in the adjuvant space at the time that it got approved. So I saw a lot of patients back in those days who would come and had heard about sunitinib and didn't want it, in part due to the tolerance profile, but also because of the question whether it really was effective. Today, of course, she would be eligible for adjuvant pembrolizumab. So Keynote 564 is much discussed, and we've had updates. And she would be considered intermediate high risk. What I typically quote patients in this setting is that the landmark analysis that was done at the 2-year mark for 564 showed a reduction in risk of about 9%. So the disease-free survival at 24 months at 2 years was 72% in placebo patients and 81% in patients treated with the pembrolizumab, which means that the relative risk reduction, if you think about the likelihood of having disease recurrence, was about 30%, which I think is actually a notable difference in DFS. And we have recently heard per press release, that there now is, with additional interim follow-up, an overall survival benefit to the pembrolizumab therapy in that setting. So the patient certainly should learn about that and then make a decision.
Absolutely. And I think the decision-making there remains challenging as we weigh treatment burden and also the benefits of treatment. But that's where these careful counseling conversations come in. So she did have a genetics evaluation. It was unremarkable. She had this risk-adapted intensive surveillance every 3 months. And we watched that little spot in her lung. But ultimately, it did grow. So what are you going to do? How are we going to work this up? This is open to the floor. So she comes back to you, Dr. Margulies.
You know, if she was older and a smoker, I would consider biopsying this because a primary lung cancer would be in a differential. But with this lady, I think you have to assume that this is metastatic RCC. I mean, I think there are options. I would favor at least a consultation with a thoracic oncologist, surgeon, to see if this could be resected. But I think, you know, SBRT also would be an option.
So just as part of the evaluation, Dr. Kapoor, any challenges in reading these biopsies of these small pulmonary nodules?
Yeah, it's a subcenter biopsy of lung mass generally is a little bit high risk. What I was saying was biopsying pulmonary lesions which are small is high risk, can lead to bleeding and pneumothorax. And we end up with very little tissue. But if the tumor is targeted, and if it's just correlating with the primary, we are often able to make the diagnosis.
So looking at the CT scan, you know, we can pretty much tell really is more likely to be oligomets or a primary lung tumor, because for primary lung usually it's more spiculated. This is actually pretty roundish, so it's more likely to be oligomets. But, you know, I would favor actually, since you have to obtain diagnosis to ascertain the diagnosis, you might as well check it out as both therapeutic and diagnostic.
Sorry, say that again?
Oh, if the nodule is being taken out, it's both diagnostic and therapeutic.
Absolutely. So she did have a biopsy that was consistent with her original diagnosis. And so at this point, with favorable risk metachronous oligometastatic disease and otherwise excellent performance status, and now she's only 40, she was referred to a multidisciplinary tumor board. So we've already heard the rule for surgery, given that it would be both diagnostic as well as therapeutic. Radiation, would you be enthusiastic about irradiating this, Dr. Lowe?
Well, I think there's certainly some uncertainty factor, but the patient is young, the patient can take surgery.
And then Dr. Voss, any role for systemic therapy in the absence of any other sites of metastatic disease here?
No role. Should have surgery.
Perfect. So she went to thoracic surgery and underwent an uncomplicated left VATS wedge resection and had the excision of a 1.5 centimeter clear cell renal cell carcinoma that did demonstrate extensive LVI. So she continued to undergo updated imaging. She had not started adjuvant immunotherapy at this point. Is there any role after metastasectomy for adjuvant immunotherapy? Does that change how you counsel patients about the need for it?
Yeah, this comes up all the time now based on the M1 data on KEYNOTE-564. So the adjuvant pembrolizumab study, 1 year of adjuvant pembro after nephrectomy, did allow for patients to enroll who had metastatic disease. Now this patient would not have been eligible for KEYNOTE-564. So if you read the fine print for that trial, patients had to have de novo metastatic disease, so their metastasis had to have been present at the time of diagnosis, and their metastasectomy had to happen within 12 months of their nephrectomy. And if you look at all the numbers in the 2 papers that are out there, New England Journal paper and the Lancet Oncology paper, then you see that every single patient who went on the trial actually had a nephrectomy. So there were no patients, at least to my understanding, that went on the study based on delayed metastasectomy, where they only went for that in their nephrectomy, dated back. Now, so if we're like, being very literal about the study, she would not have been eligible for it, and the data of the M1 patients don't apply in her. Now, what is the data? So was just under 60 patients that were randomized on KEYNOTE-564 with M1 resected disease to receive pembro versus adjuvant, and those are the ones that showed the strongest hazard ratio towards a DFS benefit, with a hazard ratio of less than 0.4, so very impressive, actually less than 0.3. And if you look at the numbers of events in the subgroup analysis, and you can see that for those who went on to receive pembro, at the 2-year mark, only a quarter of them had suffered disease recurrence. If you look at the placebo arm, about 2/3 at the 2-year mark. That gives you a little bit of a sense of what it is. So there's clear benefit from pembro at the 2-year mark. What we don't know is, long-term, how many of those patients were actually cured. And I think the key question that comes up as we consider these patients, are they better served to be treated for metastatic disease with combination strategies? What we see, we have even more room for improvement in that. And there's no data for that. We don't have data for combination data in patients who had disease resection. So I think in a patient like this, to answer the question directly, I think she deserves an open discussion of the data with all the limitations of it. If this patient were interested to pursue adjuvant pembrolizumab with me, I would offer it to her, understanding that the data doesn't fully apply in her, but that there might very well be benefit.
And that's the world that we live in. Sometimes we're making these very challenging decisions with suboptimal data. She did opt for initial surveillance, but then ultimately, after further consideration, decided to proceed with adjuvant pembrolizumab. And so she actually got it started, and her scans were negative, but then she called the clinic complaining of intermittent dizziness and imbalance. It was specifically positional, and it triggered the sensation of room spinning. She's had worsening headaches. We referred her immediately to the ER to have her head imaged, and unfortunately found multiple foci of brain metastases. So in the setting of an acute presentation with multifocal brain metastases, Dr. Lowe, Dr. Voss, what are your immediate next steps, both in terms of clinical management, stabilizing the patient, and then we'll talk a little bit more about how we're going to handle this.
So the first thing is I would talk to medical oncology regarding, the patient, if the patient is being considered for immunotherapy, how likely it is going to shrink those masses. Yeah. And since the patient is symptomatic, we need a more rapid response. So I would favor the local approach, namely radiation therapy. And there are different approaches. Is it a whole brain radiation or stereotactic radiosurgery? But I would favor stereotactic radiosurgery despite the fact that there are multiple lesions like this, because number one, renal cell carcinoma is regarded as a relatively radio-resistant tumor. And number two, this patient is young, and if the patient is expected to have a relatively long life expectancy, we don't want to give the patient neurocognitive and short-term memory deficits. So with stereotactic radiosurgery, one can actually spare the neurocognitive function much better than whole brain radiation.
Yeah, I fully agree. So with immediate next steps, the patient's got symptomatic CNS metastases, so she needs steroids and the radonc referral. If it were isolated or larger bleeding tumors, then neurosurgery steps in. We typically involve both teams for all patients, but in this case, very quickly, this would be a radiation oncology referral. And I can't remember the last time that our radiation oncologist recommended whole brain radiotherapy for all the reasons that you outlined. So I see patients with many lesions throughout, the bilateral brain receive SRS to individual lesions. The next question, which is sort of not the immediate one, but the longer term one, is what to do about her systemic therapy. But I think we'll get to that later.
Absolutely. So immediately, she was referred to a local ER. She lives fairly remote from Seattle, where I had been taking care of her, and she ended up in the trauma center for neurosurgical intervention. Was treated with steroids and anti-epileptics, with an improvement in her headaches and her dizziness and her balance issues, with an urgent neurosurgical consultation that was then deferred because of some improvement in her symptoms. Neurosurgery did see her, as did medical oncology. She was actually recommended for whole brain radiation and a cerebellar mass resection with delayed SBRT. And this is what this brought the complexity of the discussion that Dr. Lowe just brought up for us. So she came back to us for a second opinion. Neurosurgery and our radiation oncology team ultimately undertook multifocal stereotactic radiosurgery, and ultimately she did really well with that. So let's talk a little bit about now what are we going to do that we have clear progression to multifocal metastatic disease?
So yeah, so I'll take that. So I don't know how far into the pembrolizumab she was at the time that she progressed, but she progressed on therapy, so she needs a switch in treatment. And now she's got CNS disease, which has its own, flavor, of course. There's limited data, prospective data that we have for CNS metastases because, almost all of the pivotal trials, actually all of them, exclude a patient with brain metastases. But there is some data to guide things here. I see she received ipilimumab, nivolumab, so there's a study called the CheckMate 920 study that was published in Cancer a year or two ago, and that was a study that followed the CheckMate 214 registration trial to look at ipi-nivo in unique patient scenarios, including non-clear cell and CNS metastases and so forth. And the report on the CNS metastases was not encouraging in terms of the efficacy. There was about a quarter of the patients had intracranial progression, and if you look at them, then most of those intracranial progressors had exclusively disease progression in the brain, not systemically. And I think it speaks to the lack of efficacy for pure IO in the CNS, and it's what we've seen outside of trials also. There is data from Europe for nivolumab that suggests sort of similar patterns. It's just, in my experience, not very efficacious in that setting. Plus, this patient, essentially progressed on PD-1-directed therapy, and we know through a number of trials now that adding CTLA-4 to a PD-1 strategy benefits very few patients, much less so than giving CTLA-4 PD-1 upfront. So I think this patient would probably best be treated with a TKI. Cabozantinib has good data in the brain. It's all retrospective data. There's a report in JAMA Oncology not too long ago where different institutions pooled data together for patients treated in the setting of new brain metastases with cabozantinib. And there are several patients in that report with a lot of selection bias, obviously, that showed intracranial regressions, so response in CNS metastases. And anecdotally, I think many of us have seen it work that way. So that would have been my agent of choice.
So she started with ipilimumab and nivolumab, progressed to nivolumab cabozantinib. She did have a brief hold for those LFT abnormalities and an episode of hand-foot syndrome, but then was able to resume cabozantinib monotherapy. She had then control of the lesions with the CNS disease that she had, but did have some new and progressive lesions elsewhere, and had increasing symptoms. And you can see here that she had some new development of osseous metastases and liver metastases, so ongoing progression. She went on to third-line pembrolizumab and lenvatinib, and then also received some palliative radiation, and is now about to start a clinical trial. I think that these cases you're going to see, they really highlight the fact that throughout all of these, at each step in the disease progression or after episodes of care, it's very common that we need to come back together and reassess the optimal care of these patients in a multidisciplinary setting. And so we're actually going to jump into the second case, which really, I think, illustrates that even further. So this is a 59-year-old male who came into the ER with blood in his urine and back pain. He had relatively limited past medical history, never had any surgery, was a non-smoker, and no family history. His physical exam was unremarkable. His labs really were unremarkable as well. He had a proper cystoscopy and hematuria evaluation, which did not demonstrate any urothelial carcinoma, and he had excellent performance status. And so here we're going to run through the imaging, and I will highlight the key findings, which are, you can see this large renal mass in the left kidney as well as the periaortic lymph nodes. On the coronals, it's a little bit challenging to see, but we'll also notice that there's going to be some osseous abnormalities. And so you can see the magnitude of the size of the disease and also the disease both within the kidney and extrinsic to the kidney. So just to summarize, we have this fairly large calcified left renal mass with central necrosis. There's a left adrenal metastasis and some bulky periaortic lymphadenopathy and a relatively large lytic mass in the transverse process and lamina of the L2 vertebral body. His chest was clear. So in this setting, we have IMDC, intermediate risk metastatic renal cell carcinoma. It's synchronous oligometastatic disease. Even though it's a fair amount of metastatic disease, it still meets our criteria of being less than 5 sites. So How are we going to proceed?
So I would not, in my own perception, I would not consider this oligometastatic disease. I mean, I think it's bulky disease, it's high volume, this patient should have systemic therapy.
Is anyone going to take an opposing point of a
I agree. I would favor starting systemic therapy first.
So what are we going to start, or what are we going to do next?
It's a tissue diagnosis.
Excellent. So we get a biopsy.
So what we are seeing is a classic morphology of a non-clear cell. So what we're seeing is a more pink tumor. The cell borders are very prominent. There's perinuclear clearing, so it's a morphology of a chromophobe renal cell carcinoma. Since there are some clear cells, it would be called classic and not eosinophilic variant.
So at this point, we have bulky metastatic chromophobe disease. Dr. Voss, Dr. Margulies, Dr. Lowe, what are you going to recommend?
So first, I would like to ask what Dr. Voss would recommend first in terms of systemic therapy.
Yeah, so metastatic chromophobe, high volume in need of systemic therapy. So it's a long discussion. So the historical perspective to metastatic chromophobe RCC is that of a disease that is responsive to targeted therapies, right? So we developed targeted therapies, VEGF inhibitors, mTOR inhibitors in clear cell RCC, and then subsequently applied them across various non-clear cell entities. And chromophobes for the longest time stood out as the ones that did well. There were responses to VEGF TKI, responses to mTOR inhibitors, maybe more so even than for other variants. And there is nice data. The difficulty, obviously, looking at all the small phase 2 efforts that have been done across different non-clear cell variants is that if you look at them individually, the subsets of chromophobes are incredibly small. You look at, we always talk about ESPN and ASPEN and so forth. All of these studies taken by themselves will have less than 20, less than 10 chromophobe patients on them. So there's only so much we know. There's a nice data set by the IMDC that was published several years ago that looked at all the chromophobes within the IMDC database, and that was about 100 patients, and that goes back to the targeted era. And they did a comparison of how patients did with all the limitations of retrospective analyses comparing chromophobe and clear cells. And with targeted therapies, and they lunched together VEGF and mTOR targeted therapies, they're quite comparable. The chromophobes don't do much worse than clear cells in that era. And I think that's how we all felt about it at the time. And then came IO therapy, and it completely changed how we manage clear cell RCC. And again, we used the paradigms once it was established in clear cell and applied it in various retrospective efforts, smaller efforts, and looking at the various non-clear cells. And now this is where everything changed for chromophobe, where the great success with deep durable responses that we can achieve in clear cell was somewhat replicated in papillary, unclassified, some of the other variants, not so much in chromophobe RCC. So if you look at the efforts that have been pursued with what we consider contemporary frontline regimen, which is what we need for this patient, in a clear cell RCC patient, you treat with IO-IO or IO-TKI. And if you look at the 920 trial that I mentioned before, the non-clear cell subsets, and again, it's very few patients, it's less than 10 patients with chromophobe, the response rate was 0 with ipi-nivo. And if you look at IO-TKI, we did a cabo-nivo trial at MSK, which is a very active regimen in papillary and unclassified. The response rate in 7 chromophobe patients was 0. There's the B61 study that's the most recently published and the largest non-clear cell trial of contemporary regimen. That's lenvatinib pembrolizumab, so Keynote B61. And that study accrued over 100 patients across entities and had about just under 30 patients with chromophobe RCC. So that is the biggest contemporary prospective cohort of chromophobe patients. And the response rate was 28% for chromophobe. So everyone sort of said, yay, there's responses in chromophobe. But if you look at the subsets of all the different non-clear cell variants, and chromophobe RCC, those 30 patients, have the lowest response rate and the highest PD rate across all the different non-clear cell entities. My own impression is that it's the lenvatinib that's carrying the weight. I don't think that the IO therapy is doing much. And if we look on the translation level, I know we are limited in time, but there's a very different immune biology in this disease. So how would I treat this patient? So I tend to give lenvatinib everolimus in the front line now to chromophobe. There's a phase 2 study that Tom Hudson has published some time ago that again has very few patients in there. And there's 9 chromophobe patients on that trial, but the response rate was in the 40s. And we know that mTOR inhibitors and VEGF-TKI have efficacy, so I like the idea of pairing them together and treating a patient like this with high volume disease. I would treat with lenvatinib everolimus.
Dr. Margulies, any enthusiasm for taking this patient to the operating room?
Yeah, I mean, most of his disease is in retroperitoneum, so large lymph node, large kidney primary. I think all of that is resectable. I do have concerns, as just has been outlined ad nauseum, that none of the systemic therapies will have. They may have some immediate effect, but certainly no long-term effect. And so I don't think there's anything wrong with debulking this patient and basically radiating everything in sight, and then switching over to systemic therapy.
We'll give you, Dr. Lowe, we'll give you a chance to answer in just a second, but in the interest of moving it along, so the plan was to actually go ahead with frontline surgical therapy, and I'm going to skip at the thought experiment because we've talked a little bit about clear cell already, but unfortunately, this is the era that we're living in, and this patient contracted COVID-19 with severe pulmonary sequelae, and so he couldn't go to the operating room. So the question is, what are we going to do now? So we've talked about systemic agents. Any thought about how we're going to control his symptomatic pelvic metastases?
Yeah. So I think in this situation, there's 2 situations where, for bony metastasis, we would consider, in the setting of systemic therapy, we will still do radiation. Number 1 is when there's severe pain symptoms. Number 2, when there's a risk for jeopardization of the neurostructures. And in this case, if the pain is severe, I would recommend stereotactic body radiation therapy to the 2 bony sites.
Perfect. So that's what he had done. So he had SBRT of 24 grade in 2 fractions given to the L2 and 3 metastases. And then he ultimately did come to surgery. And then as Dr. Margulies alluded to, the goal here was really to sterilize surgically the retroperitoneum. Here's his pathology. So he had a very large chromophobe renal cell carcinoma with some focal sarcomatoid differentiation and also had those 2 adjacent periaortic masses. It was a PT3A tumor invading the perirenal fat as well as part of the renal vein. And there were separate drop metastases in the perirenal adipose tissues, and he also had 6 out of 9 lymph nodes positive. He unfortunately had a relatively challenging recovery with high volume chylosocieties. This is not uncommon when you have this kind of bulky retroperitoneal disease. Dr. Margulies, any just sort of quick view on how you handle this in terms of stepwise management of recurrent chylosocieties?
So this is unfortunately, this happens, especially with right-sided tumors and patients that we treat for testicular cancer. The management is not super standardized. We all have our different pathways of managing that. For me personally, I think first thing is the diet, right? So you put them on extremely low-fat diet, medium triglyceride chain diet, and then I used to put drains, but now I utilize periodic paracentesis, and most patients with proper diet and periodic taps will eventually resolved. I had a patient that had to get 6 or 7 taps and eventually stopped. If that doesn't work, the other interventions include lymphangiograms that can be diagnostic and therapeutic. And finally, here is probably the last resort. Well, maybe not the last resort, but one of the last resorts is a Denver shunt, which shunts the fluid from the peritoneum into the heart. Although every time I've done that, you literally within a week the shunt thrombosis because of the chyle is very viscous. And finally, the last option, I think that's really the last resort option, is surgical intervention to look and surgically control the lymphatic leak.
Yeah, it's a very challenging clinical scenario, but as you said, it's really sort of a stepwise progression. as the patient was recovering from surgery, unfortunately, CT scans demonstrated mesenteric stranding that was concerning for peritoneal carcinomatosis and some new liver lesions. So now we have progressive metastatic chromophobe renal cell carcinoma. And so at this point, I think we're looking towards starting that systemic therapy that you pointed out to. So your one choice for therapy at this point is what, Dr. Voss?
Well, the addition to what I said before, lenvatinib everolimus, what I think an important addition that came out of the PATH report here are the sarcomatoid features. So chromophobe RCC with sarcomatoid features, that's a specific variant within this variant that these patients do very, very poorly. It's about 20% or so of the chromophobe patients that we see. We've looked at this because I picked up on this as a fellow. I was in Bob Mozart's clinic as a fellow many years ago, and I had 2 or 3 patients within a year or 2 that had chromophobe sarcomatoid, and they just crashed through all the therapies that we gave them, responded to nothing. And I talked to him about it, and he said, oh, I've seen this again and again through the years. And we started to collect patients at the time, and we published a paper. Yasser Ged, who's here, was the first author on this. In 2017, we published a paper of 29 patients with this entity. And for one, we looked at post-operative courses for these patients after their nephrectomies, and they recur incredibly fast. All of them recurred. There was not a single patient who didn't have metastatic recurrence. The median time to treatment failure on first-line therapy is 1.8 months, which means no one responded to anything. And we've looked at subsequent therapies, and they didn't respond to second, third line either. Now, that paper was published in the times before combination immunotherapies, and there are some reports, isolated stories that people tell of patients responding to doublet or triplet therapy, so it's worth treating a patient aggressively. But this is a very, very poor prognosis for this patient. You can already see, from the course that they're not doing well.
So he went on to lenvatinib and pembrolizumab and did have disease stabilization for 9 months, but then subsequently, as you alluded to, developed progression with increasing pelvic pain. And so I think we've talked a little bit about the management of symptomatic osseous metastases, Dr. Lowe. I just want to actually ask you, specifically, do you note any differences, or is there any data to guide us when using SBRT or radiation therapy across histologies? Is there any difference in responsiveness?
So actually, in the clinical trials comparing conventional radiation therapy and stereotactic radiation therapy, is histology agnostic. So they don't specifically, they exclude those hematologic tumors, but I think they lump everyone together, like renal cell, lung, breast, prostate, everything. So we don't have any specific data.
And so ultimately, he did begin palliative radiation, and then ultimately has started cabozantinib with a reduction in his hepatic metastatic burden. Okay, case 3. This is going to be a bit of a lightning round here, so because we want to get to that bonus case. So 65-year-old male presenting with intermittent right upper quadrant abdominal pain and unexplained breathing problems that he noticed after swimming off of his boat. And this pain has been present, but it seems to be getting worse. He's got hypertension, he's had an appendectomy and some orthopedic operations, not a smoker, he's married with an adult son, has a family history of lung cancer in his father who was a heavy smoker. Has an unremarkable physical exam. His labs are notable for an elevated LDH and a slightly low platelet count, excellent performance status. And you note on his imaging, in addition to a 5-centimeter renal mass with a level 0 renal vein thrombus, there's no adenopathy, there are several small pulmonary nodules, and he has a lytic lesion in T2. Now, his bone scan's negative, and the only reason I put this in is because, unfortunately, bone scans are oftentimes not sensitive enough to pick up the lytic renal cell osseous metastases that we see, and so that's just an important point for those of us who, especially for trainees, that you can't rely necessarily on a bone scan to stage the skeleton in these patients all the time. Okay, Dr. Kapoor.
So we have a classic clear cell histology, nice nest with vasculature around it, clear cells, so it looks largely low grade here.
And as you said, it was a grade 3. We've just been gifted the gift of bonus time, so we actually can take our time as we discuss this. Thank you. So we have a 65-year-old otherwise healthy male with synchronous stage 4 oligometastatic clear cell renal cell carcinoma involving the bone and the lung, and he's not having any osseous pain at this point. So how are we going to approach this? We have clear cell. Is this a patient we should be thinking about a cytoreductive nephrectomy in? Are we going to start with systemic therapy?
So I think the most pressing issue in terms of a timeline to think through for this patient is spinal disease. It's distant metastatic disease with a spine lesion that, is a little anxiety provoking from the location and look of it. He's not symptomatic from the primary, and he's IMDC intermediate risk. I would treat this patient up front with systemic epi-nivo while they meet the spine surgeon and radiation oncologist. And the benefit to that is if he needs an intervention, be it radiation or spine surgery, he can do that right after he starts systemic therapy. I do think he's a good candidate for cytoreductive nephrectomy. I just don't think he should do that up front. So I think ideally he starts epi-nivo, he manages the spine, we'll see how he does on the epi-nivo, and then he has a nephrectomy.
In situations like this asymptomatic spine metastases, actually there are two factors that we consider in terms of whether we need to treat a patient relatively urgently. Number one, it is the extent of epidural disease, and actually we do that using the Bilski grade. Mark Bilski actually is from Sloan Kettering. So Bilski 0 is like there's actually absolutely zero epidural disease, and then low grade is like 1, 2, and 3 would be high grade. In this situation, when I look at the CT scan, it looks like the lesion is located in the bone itself without actually breaking any cortex, so it's unlikely to be like anything more than Bilski grade. Maybe I'm wrong. But it looks like it's within the bone. There's no breakage of the cortex, so probably at most it's Bilski grade 1. And the other thing we look at is the spinal and instability neoplastic score. So there are 6 factors, including like the location, where the lesion is located, the nature of the bone, whether it's lytic or sclerotic lesion, whether there's any spinal deformity, and also the nature of the pain, whether the patient has evidence of mechanical pain, and the other thing is whether there's any posterior elements involvement. So there are like 3 different groups based on the score. 0 to 6 is low risk of fracture. 7 to 12 is intermediate risk, which we call it potentially unstable. And then 13 to 18 is high risk. So for low risk, we don't actually need to even consider surgery. For high risk, we need to seriously consider surgery. Somewhere in between, it depends on, so I think that's when the spine surgeon evaluation is, the spine neurosurgical evaluation is really important, because the spine surgeon need to examine the patient to determine whether there's any instability, mechanical instability. So typically, when the patient, flexes or, extends the spine, if there's increased pain associated with that, it's very likely the patient has instability. So that is actually, I think, is a marginal case, and it really depends on whether the patient is willing to undergo surgery.
Yeah, so I think critical points here that were just raised are, one, in somebody who's diagnosed with a lytic lesion in the spine, even if it is not acutely symptomatic or affecting the spinal cord imminently, we should get the neurosurgical team and the radiation oncology team on board so that they've already seen the patient and we have sort of easy access in the event that we will need their services in the future. These were the options that were considered systemically by the team that was treating the patient. To Dr. Voss's point, I think one question that sometimes comes up is there any additional evaluation that you would be thinking about in someone who you are going to give? In this case, the team opted for cabozantinib and nivolumab. Any further preparatory evaluation?
I forget what the prior medical history was. I mean, the one thing for any of the TKI-containing regimens, if the patient has a long-standing history of hypertension or other cardiac risk factors, we get a baseline echocardiogram.
And then one other thing, as we talked about, we had this MRI, or the initial imaging that was concerning for the lytic lesion. The bone scan was negative. The team that was taking care of him tried to get an MRI of the bone marrow. Unfortunately, it wasn't covered by his insurance at that time, so it ultimately wasn't performed. He did have an echocardiogram that demonstrated a normal EF, but there was an incidental septal motion abnormality, so he was referred for cardiology. He underwent baseline urine protein testing and careful blood pressure monitoring. So he starts nivolumab and cabozantinib, and you see his transaminases begin to climb. So what do we do?
So this goes for any of the TKI-IO regimens. We hold both drugs and see what happens without institution of steroids if we can avoid it. And that way, if the LFTs level or improve with only holding the cabozantinib, we know it's the oral medication. If they continue to rise, we give steroids.
So the Nivo and Cabo were held, and he was in this case placed on a steroid taper for presumed autoimmune hepatitis with resolution and normalization of his transaminases, and then the cabozantinib was reinitiated. And as he was starting the cabozantinib again, he came in saying that he was having this new pain that was wrapping around his right upper back into his right axilla. And repeated imaging demonstrated now a change in the appearance of his lytic lesion, as well as some new osseous metastases. So he now has this compression deformity of the T2 vertebral body with, that's concerning for a pathologic fracture. And you can appreciate here the kyphosis at T2 and the retropulsion of the fragments deforming the cord. So going back to, as you were talking about before, Dr. Lowe, the Bilski score, now how would you grade him?
Based on the best I can tell, it is actually maybe touching it. So I would say probably if I try to, err on the safe side, I would call it a Bilski 1C, just barely touching the cord but not deforming the cord with CSF surrounding the spinal cord.
And so as you talked about before, this is the criteria that is used to generate treatment decisions in patients who have spinal cord compromise. We can share with you, this is a nice algorithm that can be utilized to manage the evaluation and the subsequent treatment of patients with spinal cord compromise related to these fractures. So, and then did you want to highlight any other points about how you think about the acute management of a patient with spinal cord compromise?
Yeah. So at University of Washington and Fred Hutch, actually all the spine med patients are jointly evaluated by neurosurgery and radiation oncology, every patient. So when a patient comes in, first we look at whether the spine is stable or unstable. Because the spine is unstable, even if there's no cord compression, we need to seriously consider surgical stabilization. And also we look at risk factors such as, whether there's any baseline vertebral fracture, whether the tumor is lytic or sclerotic, whether there's any spinal deformity, and whether there's any mechanical pain, and also whether there's any high-grade epidural disease jeopardizing the spinal cord. And any risk factors, the patient should go to surgery if the patient is deemed to be suitable for surgery, for stabilization plus or minus surgical decompression. However, if the patient is not suitable for surgery, then we have to consider the patient for radiation, understanding that that is not a perfect solution. And if the spine is unstable, then surgical intervention would be highly recommended.
And I think one question we should ask ourselves right now is this a treatment failure? Is this the cabozantinib is not working? And the impression of the team was basically, don't forget that this patient really hasn't seen much systemic therapy because the drugs were initially held for that autoimmune hepatitis. And so this was considered progression in the absence of treatment. So at this point, given the symptoms that he's having and the appearance on the imaging, you can see that the pain that he's experiencing is directly corresponding to the innervation distribution from T2. So he was referred to neurosurgery and radiation oncology for consideration of surgical debulking, stabilization, and postoperative radiation therapy. He continued management for the autoimmune hepatitis with a steroid taper, and he's on gabapentin. He's also taking the cabozantinib. But the cabozantinib had to be held in preparation for surgery. He did have a preoperative spinal angiogram for possible tumor embolization, but there was no angiographic source for embolization identified, and so he ultimately underwent a T2 separation with T1 to 3 posterior fusion. He had a smooth recovery. And I just wanted to ask you, Dr. Lowe, if you can talk to us a little bit about how you think about adjuvant RT after surgical stabilization like this.
Yeah, it would be necessary. Otherwise, the risk of a recurrence would be very high. So typically, after the surgery, we wouldn't do it actually sooner than 3 weeks. The main reason is, in order for the bone to grow into the implant, it takes at least 3 weeks. It's just like if you have a fracture anywhere, in a bone in your body, it takes 3 weeks to form a stable bony callus. And so if we do it too early, we may risk a non-fusion. But we shouldn't be dragging on for too long. Then, when a tumor recurs, bulges into the epidural space, we're starting from square one.
That's a good point. So he underwent SBRT, 27 gray and 3 fractions. He developed a postoperative seroma after the surgery and the radiation, which did become fairly bothersome and was managed with FNAs, and then ultimately an incision and debridement. So at this point, if we just look at his treatment course, he was initially started on nivolumab and cabozantinib. It was immediately held relatively quickly for autoimmune hepatitis, and then the cabozantinib was briefly resumed before stopping it again for the treatment of his pathologic fracture. But then ultimately he resumed it again and then developed hand-foot syndrome. Updated imaging, unfortunately, demonstrated progression of osseous metastases, but we do see that the left renal primary tumor is decreasing. And so at this point, we are now holding the cabozantinib, given his hand-foot syndrome. And so one question, Dr. Voss, that comes up sometimes, are there any other medications we should be thinking about that for protection of the skeleton in the setting of high-volume osseous metastases?
Yeah, so the registration trials for zoledronic acid and denosumab in patients with solid tumors and osseous metastases did include kidney cancer patients. So there was, sense in using it up front. There's been some dedicated series that have been published in RCC looking at bisphosphonate and denosumab therapy in RCC, and there was some conflicting data. Early on, there was the sense that it may actually improve outcomes when added to TKI therapy. And then there was a very large retrospective, actually it wasn't a retrospective series, it was pooled patients from clinical trials. Raina McKay was the first author on this. This is a few years ago that this was published, looking at patients receiving TKI in the first line, a couple of hundred patients, I think it was over 500 patients who had osseous metastatic disease, and a proportion of them had received bisphosphonates and the others didn't. And that study did not confirm any benefit in terms of cancer-specific outcome to adding the, in that case, bisphosphonate to TKI therapy. And there was also no reduction in skeletal adverse events in that data set. And I think a lot of people at that point stopped using bisphosphonates and then denosumab altogether in RCC. So when I talk to my colleagues, I think there's people who never use it. There's few people who use it religiously, the way it's being used for prostate cancer and so forth. In my own practice, what I try to do is I try to gauge the burden of disease, because when I think about that large data set that sort of led to this shift in use in our field, we didn't get a lot of detail as to who these patients were and how much metastases they had. I think a patient like this, who's already had a skeletal adverse event and has a large burden of osseous metastatic disease, multiple bones in the body, I would give that patient denosumab. And I would give it now if I hadn't given it before, and it's typically tolerated okay.
And then he obviously has had pretty significant severe adverse events and treatment toxicity to date that has actually precluded him from really receiving a lot of the therapy that we had hoped to be able to administer. Would you re-challenge him with nivolumab, given that he's only had one dose?
So we have re-challenged patients like this successfully, and some patients, the hepatitis recurs, and in some patients it doesn't. The thing that I always look at is how quickly were we able to manage it when it occurred. So someone who had a very swift response to steroids and was able to taper off the steroids quickly is someone I might re-challenge, and someone who took months and months, or infliximab or like badness, in order to come clean with the transaminitis, I'd be, obviously less excited to challenge. The other thing you could think about is trying a different agent. So you could give them lenvatinib pembrolizumab instead of cabo-nivo. There's very little to no data in that setting for it, but it's a unique case, so it's something you would consider.
So with slight modifications in his dosing, he did successfully resume nivolumab and cabozantinib, and ultimately had stability in the sites of metastases that we were aware of. However, he did have some small progression within the liver and the para-aortic lymph nodes. So at this point, we've talked a little bit about potential second-line therapy. Is there, and I'm going to just move here. So Dr. Margulies, he's asking now about his primary. The primary has been relatively quiescent. It's actually shrank in size, but he's worried that that's the source of all of his problems. How are you going to talk to him about a cytoreductive nephrectomy?
I mean, it would have been a reasonable consideration, but now that he has progression in the liver, generally, I think that really the primary is the least of this patient's problems. It seems to have responded well. It seems to be stable. It's not producing any symptoms. I think last thing I would want to do is now put this patient through surgery and then interrupt what really is going to be life-prolonging systemic therapy. So I think I would vote against it. I mean, certainly if there is significant period of disease stability at some point, that's a consideration, but certainly that doesn't seem to be the case now.
So he started lenvatinib and everolimus, actually tolerated that well with good stabilization of his disease process, of his metastases, and he's really working on resuming function. Okay, so last case. We have a 37-year-old female who came into her local ER with abdominal pain. She underwent the requisite CT scan, and this is what was found. So she had a right lower pole renal mass with some pericaval and retroperitoneal adenopathy. She underwent a robotic-assisted laparoscopic right radical nephrectomy. So, Dr. Kapoor, can you just walk us through what you're seeing here with her path?
Yeah, so the H&E image shows a non-clear cell tumor. It doesn't have the vasculature even of a high-grade RCC. It's a pink tumor. It's high-grade. It has this mixture of pink and white cells near each other, which is suggestive of you should think of translocation RCC, and FISH is positive here for breakpoint.
And of course, with her age and female sex, that of course is something that is high on our differential. So at surgery, she was found to have a T3A N1 M0R0 TFE3 rearranged renal cell carcinoma. 4 out of the 8 lymph nodes were positive. There was no extranodal extension. So if we'd had a biopsy before she came in with clinical or radiographic retroperitoneal adenopathy and the mass, would this have changed our management at all? Is there anything anyone would have done differently? Dr. Margulies, would you have taken her to surgery?
I would say that if this was clear cell, possibly not. I mean, this is a pretty heavy burden of extra renal disease, so I would consider systemic therapy up front, but certainly with translocation or some of the other variant histologies, I think with surgery remains the only way to really have the highest probability of curing her. I think I would have done the same thing.
And so she did undergo, she was recommended to undergo genetic testing. And then let's talk a little bit about follow-up and next steps. So Dr. Voss, how would you talk to her?
So the question of adjuvant therapy will come up in her, and there's no data for it. So, right, this is not clear cell RCC. The keynote data does not apply in her, and this is where the emotional conundrum of someone in their 30s starts, where you wonder, well, because there is no data, does that mean that it's not effective? Should we treat her anywhere? She's not going to be eligible for the current trials that we have. The biggest trial that runs globally right now is pembrolizumab plus minus belzutifan. She's not going to be eligible for that either. So the way I would approach it is you think about the likelihood of her disease responding to single-agent IO therapy, and that gives you a sense of how helpful adjuvant pembro might be for her. We have data from the metastatic setting looking at TFE3 translocated RCC. Dr. Gett gave a great overview at an earlier session here. And although for contemporary regimen TKI-IO combinations can achieve good responses, I would say the overall experience with IO monotherapy has been very disappointing in translocation RCC. So I've been in this scenario, and I do not recommend adjuvant pembro for that reason. And it's a difficult situation. But remember, there's a good chance that she was surgically cured, and I think more than anything, she needs very close follow-up. And in the case of recurrence, I think combination therapy up front.
So we recommended close follow-up. Unfortunately, this patient has had trouble getting in for her scans, but we got a scan 1 year later. This is what it looked like. But 2 years later, this is what we see. So you'll notice that there's a growth of now para-aortic lymph node disease, and you'll also notice her somewhat complex vascular anatomy. She has a circumaortic renal vein, and the node is right in the middle of the two vein limbs. So there's this necrotic left para-aortic lymph node mass. It measures about 4 centimeters in size, and now we're dealing with a situation of metachronous oligometastatic disease in this patient with a translocation tumor. So what are we going to do?
It's been 2 years since her surgery. I think she should go back to the OR for this if it's resectable.
Yeah, I agree. I mean, this is a surgical disease. I don't think any systemic therapy is going to cure this patient, and would probably leave radiation therapy for something that I couldn't get.
Dr. Lowe, any enthusiasm for treating this differently?
If surgery is feasible, I would favor surgery first, and radiation will only be given if, number one, the patient is deemed not to be resectable, number two, when there's a residual disease after surgery.
And so remember, she has a solitary kidney. Just out of curiosity, are there any concerns about radiating the mass that close to her solitary kidney in terms of renal function?
You know, usually what I do is, number one, I look at the estimated GFR. That applies for, any targets close to the kidney. And then, when we generate, we estimate, whether we could achieve the sparing of the kidney from the get-go. And then when we, plan radiation, we actually estimate how much EGFR would be left after the treatment. If it is about 15, I think, we'll discuss with the patient. If the patient is willing to proceed, we'll do it. But in this case, actually, it's quite easy. I think we can achieve it, even for a solitary kidney. Yeah, based on my experience.
So she unfortunately was then lost to follow-up due to a family tragedy, but then did re-present and said that she was ready for surgery. So you can see what the nodal mass looked like just before surgery. Dr. Margulies, any concerns as you're planning this operation, as you're thinking about the dissection, your approach? How would you tackle this?
I mean, this would have to be a completion, so I imagine you already done a template on the right side, so this would have to be a left-sided complete template, RPLND. I mean, obviously, solitary kidney with complex anatomy. I think you can sacrifice the retroaortic renal vein pretty simply and still preserve the function of the kidney. So I would go in with an idea to completely sterilize the retroperitoneum at this point.
And so this is what the mass looked like. You can see the nodal burden. There was actually some additional tumor inferiorly, and then we did, just as you said, and sacrificed that lower vein branch and basically cleared the retroperitoneum. And so the periaortic masses and lymph nodes were completely resected. 2 of the 14 nodes that were removed in the templated dissection were consistent with the prior TFE rearranged renal cell carcinoma. The largest tumor was 1.5 centimeters with extranodal extension. And then any rule for systemic therapy now, she's been surgically rendered NED.
Yeah, I don't think that my recommendation would change. I think it's similar to her initial presentation. I didn't see that her chest was imaged at any point. But
it has been, and it is clear.
And then the one way I changed and this is across variants, the one way I changed my approach in patients who now have established metastatic diseases, I do include brain imaging in all patients with the surveillance. So once a patient has metastatic disease, I look at the brain once a year.
And so this patient is on close observation at this point and doing well. So I think that I want to thank our panel for a really thoughtful discussion of some fairly challenging cases. I hope that we've highlighted for you that oligometastatic disease requires a truly multidisciplinary team-based approach across the course of the disease. And also, obviously, we're working here at providing risk-adapted and priority concordant therapy with the goal of balancing disease control, treatment burden, and side effect mitigation, often in situations where we have imperfect information. So thank you all so much. It looks like we have a question. We'd love to take that.
Such a great session, and I think the organizers should be applauded for putting such a great program. I think whenever I have a chance at this meeting to share a Chris Wood anecdote, I'm going to do my best. And so I had a number of patients I shared with Chris that had major abdominal operations, and when he ran into chylosocieties, what he taught me was depot-octreotide can go a long way. And so we put patients on no-fat diets, give them 2 depot-octreotides separated by a month, and it would dry up in virtually everybody. So that was kind of his trick for those scenarios, and it worked pretty well. The other thing I think on bone mets, and I really like the discussion, I think we're always thinking about oncology, are combinations causing, is there any evidence of synergy? And I think we are seeing synergy with TKI and the bone modifying agents in terms of causing osteonecrosis of the jaw. So definitely having dental involved is crucial, but as our management has really evolved, we're doing so much more stereotactic radiation. And when we're giving stereotactic radiation to the spine, the risk of compression fracture is so high that I think if you're not stabilizing in some way, giving them bone modifying agents is really important. What we've really learned with denosumab over time is that abrupt withdrawal of denosumab can actually rapidly increase fracture risk. And so these are patients where we actually, if patients are going to come off of denosumab, will often receive a dose of zoledronic acid trying to minimize that hyper increased risk of fracture. So we have a really neat, want to give a shout out to my postdoc, Stefan Maksimovic. He has a great poster of a bone model that we're working on for kidney cancer, and very happy to see that highlighted in the discussion.
Thank you. Those are great
so
comments.
one comment about a combination of Sumeda and SBRT. There's actually a phase 1 study from France showing that if you combine Sumeda with SBRT, there's some protective effect against VCF. It's published in our Radiation Oncology Journal, the Red Journal. So you're interested attendees, I can, send you a copy of that. But, we wouldn't just give that as medical oncology to give that just because we're giving SBRT, but if the patient is already on Sumeda, we won't ask them to stop because actually it does help.
Great.
Great panel, guys. Thank you so much. Question for Martin. You talk a lot about adjuvant therapy and our lacking of biomarkers. Have you ever used ctDNA in translocation non-clear cell for monitoring? Thanks.
Yeah, so I've invested a lot of time into ctDNA development at our own institution. We have an in-house assay. Actually, we've had 2 different assays, and we've had a really rough time getting that to work in RCC. You've heard this, through the years in many sessions. There's very limited tumor shedding that is ongoing in this disease, and we can't quite reproduce what we see in the tumor using conventional ctDNA approaches the way we can in bladder cancer or lung cancer. Natera has a growing effort in using their Signatera proprietary assay across diseases, and they've had a poster or 2 in RCC also, and then there's methylated DNA, which seems to be more promising in terms of picking up on disease burden. To my understanding, there's no data that's been shown from adjuvant studies in that regard, and I don't know if there's something that Merck has in the back pocket that we're going to see in the future. So as of now, I don't use that at all, but I know a lot of people have started to tinker with Natera because you can sort of try to sign your patients up for it.
Thanks to the panelists. Another question regarding case 1, thinking to our patients who have de novo oligometastatic disease. So as Martin pointed out, we just had a press release that KEYNOTE-564 met their survival endpoint. We haven't seen the data yet, but when we do, are you calling your patients back, those who made an informed decision and declined adjuvant? Are you calling them back to offer it? And if so, in what time frame? The patients in that study had to start within 3 months of their surgery. Are you pushing that envelope at all and offering it a little further out in light of new data?
So, the adjuvant discussion I have with patients tends to be more extensive than the metastatic discussion based on all the back and forth and the unique scenario of, them possibly being cured already. And I always talk to them about the overall survival data and what it means that it's been lacking and that we may see it in the future. But I don't think that I'm going to be, I might call back a patient now that I've seen, 2 weeks ago with that update. That it just hasn't been the case for me. So no, I'm not going to be calling patients back that I saw half a year ago. And that goes to your second question, right? So patients who are eligible for 564, who are eligible for the current study, have to be within 90 days of their operation. That's something that comes up more frequently for off-the-shelf pembrolizumab in the adjuvant space. I would not deny a patient who is 5 months out from their surgery adjuvant pembrolizumab. I would speak to them about the fact that the data doesn't fully apply to them and that the numbers I quote them may not be 100% accurate based on that. But the principle applies and the patients should have access to it, especially now that we know it's life prolonging. Would I treat a patient who's 6 months out? I think it's a long discussion with the patient, and if the patient, I think, is in full understanding of the limitations, you know, I think that patient could be treated. Would I treat a patient who's a year? No, I don't think I would. Right? So, but no one can give us sort of a hard, you know, hard line of where we should or where we shouldn't. I think the patient is part of that discussion even more so than in the metastatic space, and we have to do our best to make them understand what the merits and the limitations of the data are.
Well, with that, I'll say thank you so much for a really phenomenal discussion. And I'd like to invite Dr. Brad Leibovich to the stage for the next session.